If you have the template, then you can know how you can proceed with your work. We should take care about these specific 7 treatment objectives, like skeletal-facial, soft tissues, occlusal plane, arch width, midlines, anteroposterior and vertical position of the incisors and molars. And these objectives should guide us throughout our treatment planning and our protocol of work. So, based on this, I'm going to show you just a very fragment of class 3 skeletal patients, which we have a lot of camouflage treatments, unfortunately. She has bilateral crossbite and asymmetry to the right and steep occlusal plane, missing first maxillary molars, which worsens the situation. And this is her occlusion. Actually, her panoramics plus 2. In some cases, when we have the mid-palatal suture maturation at the stage C, we can also, in these patients of age 19 or rapid maxillary expansion. But he brought and coming, I was afraid I cannot control her, so we decided just to expand the arch with segmental technique. In these cases, when we have bilateral crossbites, we have to raise the bite a lot. And while I'm talking about raising the bite, there is one person, Bjorn Ludwig, who influenced me a lot during my learning, and I learned a million things from him beside this trick. So he suggests that you can bend an X ligature throughout the bend, and then you can place this bite raise, flowable, composite, or OptiBand, whatever you are using. At the point that you want to take it out, you just cut the wire and it goes out. It's a very nice trick not to go on with drilling and take a lot of tooth substance with it. So if you are not careful. So we decided to go with segmental technique. I put 0.16 stainless steel wire to the premolars only. And then the base arch wire is 0.18 with 22 stainless steel. And we made this step, buckle step, and activated the step just by ligating it in the area between the premolars. Also here, the crisscross elastics would be helpful just a little bit to help us buccalize this lateral segment. So in around 16 months, we improved a lot of her appearance and aesthetics, which were her chief complaint. And as Nanda states at that individualized orthodontic treatment planning, the soft tissue objectives should be set in terms of direction, more predictable, rather than magnitude of change. Because in adult patients, it's almost impossible, at least for me, to predict the soft tissue changes when you are not using softwares, when you are not using technology to predict the patient look, and if you work with simple mechanics, then it's very difficult to predict the soft tissue changes. Of course, we had only soft tissue changes in the septum and not skeletal changes. She remained with a slight of black triangles in the mandible, which we could also could correct them with stripping, but we decided not to compromise. We were afraid that we could have a relapse in the mandible. Therefore, we decided just to do to leave them like that, and then she can make some small UV composites build-ups or whatever. So this was her smile at the end, and we know we didn't do an excellent job, of course, but it's just better. So what I'm going to share with you now is my deepest challenge, because in Kosovo, we don't have CT scan. We depend only on 2D images. And just lately, we are introduced to 3D images. So what are the challenges and mistakes that we face working with simple mechanics? So we know that in order to plan the treatment timing, age and skeletal age is a very important factor, actually. So when I used to see patients like mine in a young age, and I saw occlusions like this, I usually would see the canines would get involved in the arch wire immediately. But we should really respect the growth pattern, because at this age, canines are just blocked, and we have just created the space for them to allow them to go to go to align to an arch by itself. You can always create the space, but take care, as I didn't take care of this right canine because the tip just hit the wire. And in order to prevent that, you can just simply make an in-out bend and allow the canine just to go down, and then you ligate it in full arch. By this, we simply respect the parodontium, and we allow the canine crown to have its own natural length, and attached gingiva follows it. So we don't have to pull the canine just because it stays up in an ectopic situation. But in adult patient, the similar case, it doesn't work like that. Either in these kind of cases, if you decide to extract or expand and you create the space, you need to find out the mechanics to pull that canine down. And if you don't have skeletal anchorage, palatal skeletal anchorage, to prevent the adjacent teeth from intruding, you can make a ligature and from the second lateral, from lateral incisors to the other side, to the molar, and also premolars, to keep the anchorage at least better. Here we decided to put also lingual buttons, so we can drag this canine down. But when you do things like that, when you use the power chain, sometimes you can face this slight defect on the gingiva, because the power chain, if it's thick, it tends to get inside the gingiva. And you can always place just a little bit of composite and put this power chain over the composite, so it won't disturb the gingiva. And then the traction continues. I always measure the pulling force of the canines, and it's usually not more than 60 grams. I tend to go slowly. This is not an excellent, but again, we improved her occlusion, we widened her arch, and this is before and after. So the challenge when you don't have CBCT scan, you need to find some additional tools to help you or guide you actually to assess the treatment difficulty. I specifically use this study from Stivarius, which helps me. There are 4 aspects that I assess according to this study to estimate the treatment difficulty. First aspect would be you assess the amount of the canine crown, how it overlaps the lateral incisor. So if you don't have this horizontal overlap, it would indicate a good prognosis. And if it overlaps up to the half of the root, it suggests average prognosis. And if you have complete overlap of root, it would indicate full prognosis. So this would be the first assessment. And then you have the assessment of vertical height of the canine crown. So from the level of the cement-to-enamel junction to less than half a way up the root of the lateral incisor, it would indicate a good prognosis. More than half a way up the root, less than full root length, it's an average prognosis. And if it's up above the full length of the root, you would have poor prognosis, but not necessarily if you have good and planned mechanics. Again, another assessment would be you should see this canine angulation to the midline. So as this angulation to the midline increases, the prognosis actually decreases. And this angulation from 0 to 15 degrees would point towards good prognosis, and more of that, more than 31 degrees, poor prognosis. It's very simple, because just with a simple ruler, you can either measure it at your screen, or if you have a 2D in your table, you can just measure it. It's just a predictable assessment. And then now you don't focus on the crown anymore, but you focus on the apex of the canine towards related to horizontal plane. So apex is located above the normal canine position. You have actually good prognosis. And if the apex is above the first premolar region, you have an average prognosis, and then you have poor prognosis if it's really placed distally, if the root is placed distally above the second premolar. So we took this image from the study And me and my colleague, with designer, we just put it in a printable version in my computer. So if any one of you wants it, I can email it to you. So I can print out this sheet and I can talk with the patient regarding the general treatment objectives. For example, we tick about the 4 assessments, and if you are in the beginning of your career and you don't want to make mistakes, it helps you to assess the difficulty of the treatment. Either in the same time, it helps you to justify your treatment or justify your treatment modalities. So it's a very simple thing that you just concentrate on your 2D, and you can visualize these assessments like this. And also in some more in other images, sophisticated images, you also can use this assessment to predict the position of the canine. Another thing that is very important, which you will see in one of my patients that I will share with you, is why do we need to know the surgical procedure? Because that surgical procedure actually defines the outcomes of our treatment mechanics. What do surgeons do with our canine? How do they expose our canines? Basically, if it's put buccally, if it's buccally accessible canine, either they do something they call circular incision, or they do open exposure technique, or they do apically reposition surgical flap or full flap closure. And for palatally impacted canines, they can do open or closed techniques. Why are these important for our treatment outcomes? The circular incision is safe. Whatever they do, or you do it by yourself, just a small gingivectomy, it is safe in terms of the outcomes, aesthetic outcomes and periodontal outcomes. But the tip is that you have to make sure to bond the attachment soon enough, like 24 hours max, or be there during the surgery, because the tissue tends to heal over and make tooth inaccessible. And you just bond your attachment, whatever it is. You know, it's easy to bond the attachment in the surgery because the tooth doesn't have this extraneous materials. You don't have dried saliva, you don't have block, you don't have organic stains from the food. You just have the thick menismus membrane, which is actually, which you just have to dry the area and etch it and put your adhesive, that's all. But specifically this technique, apically repositioned surgical flap, we have this excellent study from Vincent Kokich and Burnett, when they conducted the study and gave us the results that this specifically procedure has a lot of negative side effects, such as increased clinical crown length that you will see in my patient, increased width of attached tissue, gingival scarring, and intrusive relapse. So while having these side effects as a technique, maybe it's a good idea that sometimes we previously discuss with our surgeon and explain them that later on in the treatment, we want to minimize the side effect of this technique and rather use open or closed surgical exposure. And regarding open or versus closed surgical exposure, there are a lot of studies. This one from Park I particularly like, and they found neither open or closed surgical technique is superior for any outcomes. Also, this study from University of Athens in Greek showed that they evaluated 159 articles about open or closed surgical exposure. They all found out that periodontal outcome is almost similar, aesthetic outcome the similar. So you can choose whatever you like. I mean, I personally prefer open surgical exposure because I like to see my teeth, and having no CBCT scan in Kosovo, in whole Kosovo, I need a little bit to see the position of the canine while I'm tracking that. But the tip is that if you use a closed eruption technique, you know, while pulling the tooth, you may create a very palpable bulge beneath the thick mucosa of the palate. So you can either do a small circular incision around the crown tip of impacted tooth, and if you delay performing this procedure, you can cause the anchor teeth to intrude. But if you have a skeletal anchorage on the palate, you can avoid this side effect. But working in simple mechanics, you have to take care not to intrude the teeth, otherwise you will create the lateral crossbite. So this is my problematic patients, and I here had 3 problems, which I will share with you. So first, what we know, even from Bjorn Ludwig and from Becker, Adrian Becker book, prior to exposure, orthodontic space creation for the canine in the arch should be completed. So here we decided to expand, create the space for the canine. But the parent of this child was an oral surgeon who didn't want to do another 2D image to see where this canine stands. We have to know that the growing patients have the tendency to have this impulse of canine to erupt. So they did an apically positioned flap and took a lot of bone according to the initial 2D image. When they saw that's not the crown there, but the root, then they took bone more buccally down to the crown. And they end up with a large scarring and a lot of bone removing. So when I saw my patient like this, after 4 weeks, after I took off the surgical dressing, then you can see the gingiva is inflamed and it has a slight bit necrosis. And what we learned from Adrian Becker's book, The Orthodontic Treatment of Impacted Teeth, is that when this surgical exposure damages contours of the gingiva, access towards tooth traction changes. So you have to begin the traction after 2 minimum or 3 months with lower forces, like less than 60, around 30 grams. So not that I was wasting time, I was dealing with a lot of side effects of this treatment mechanics. So this is the second mistake I have done, because at that time, like 10 years ago, I was in the training somewhere in Europe, and I found out that the canines can be retracted with this overlay piggyback technique. But this is wrong. And if you have to use in conventional brackets an additional wire, then you have to use it from the molar to molar, and just in between the central incisors, you can ligate it in order to avoid friction. This is too much friction. And we know that if we have a lot of friction like this, we risk to a hyalinization of the periodontal ligament. So this is wrong. And after learning this mistake, today I changed completely the treatment. So if you can see now, the crown of the canine is largely big. The attached gingiva is outside. And because the bone was taken a lot, it was impossible to change the torque. No matter how much I tried to change the torque, positive torque from the canine, it was impossible to give a negative torque. They liked the outcome. They were very happy. They insisted in taking off the brackets. Although I would certainly go on with playing with the torque of the canines. But this result is not good, because we are orthodontists and we have to see our mistakes. You know, a few years ago, actually this is the study where there's a perception of smile aesthetic among orthodontists. And a lot of orthodontists think that the torque of 0 degrees and the torque of -5 and -10 is most desirable for orthodontists to see, while the torque of +15, which I obviously had at my patient, or +10 or -15 is less desirable. A few years ago, I started to think differently about my mechanics, and I started to think, what do we call smart mechanics? I think that we all have to know our appliances. What are their features? We have to know the forces. We have to know our limitations, and then we can maybe predict results better. So as long as we respect the biology and biomechanics, we can simplify our problems. I really now started to use self-ligate brackets, because a few years ago I listened to this wonderful doctor from New Mexico about their double round, double arch wire technique, and his techniques were a lot based in stimulating the bone, stimulating the formation of the bone, the position of the bone. While now frequently last 2 years, because 2 years ago these brackets were introduced in Kosovo, so I started to use them regularly to facilitate different movement, especially in canines, because you with these self-ligate brackets can avoid these dual arch wire scenarios. So I started to look better on these brackets and to learn more about these brackets. So I found that this bioactive system of Forestadent has an active bracket system and passive bracket system. This passive bracket system has a deeper slot. This is wonderful to know these informations, because if you know this information, you can use it, for example, placing these passive brackets only in the incisors, central incisors, enclose huge diastemas with low friction, while in the posterior area, like when the arch fools the slot, you can have full active control of the torque, and you can influence the torque of the crown and the root. So you can combine these two brackets and actually do two different techniques in the same patient. And what we learned from Domingo Martin a few days ago in this webinar, we saw that we can also change the prescription of the canine torque, which I would definitely do differently with these patients, which I done a few years ago. So by this, I really hope I'm on my time, and I want to thank you for your learning. I hope you didn't have too much problems with the screen sharing. And I think we have one thing in common. We all tend to bring smiles to our patients. We all tend to improve their aesthetics. We tend to improve their occlusion, and by that their function. So I know I'm not doing an excellent job. I'm quite restricted in laboratory support. We have no laboratories at all that can support our work, but I hope I'm doing a better job, and I hope that some of you will relate to my story. So thank you very much for your kind attention.